Hey, good afternoon, everyone. Welcome to the first post-summer break Multihead seminar. I'm Michael Jr., and I have some interesting cases collected over the summer for you. I thought we could start with something a little bit more common. So this was a 50-year-old patient with a small polypoid tumor on his chest wall. So you can see the skin excision here in the scanning magnification with this kind of like multilobular tumor, very well circumscribed, which has kind of like this interesting morphology where you can see these little nodules formed by its hyalinized core, and the tumor cells are arranged at the periphery.
Matchsticks.
Yeah, a little bit. In some areas you can see this very well, such as here in the center somewhere. In other parts it's less pronounced, but generally this arrangement is very frequent here. Although the center here it's actually some hyalinized material, some collagen. It might resemble some I think it's called neuropil or something like that, right? And this is likened to the arrangement of neuroblastoma. By immunohistochemistry, this tumor is diffusely positive with S100 protein. This is S100. All tumor cells are positive. And also with SOX10, again, all tumor cells show nuclear staining with SOX10. And everything else was negative. When you look at the tumor cells again, actually I didn't mention that there is no really prominent atypia, no mitosis, no mitotic activity, no necrosis, no worrisome features really. So with this immunophenotype and this morphology, this is called the neuroblastoma-like schwannoma. So it's basically a pretty rare morphological variant of a very common tumor, which schwannoma actually is. So neuroblastoma-like schwannoma, you should always have S100 SOX10 diffuse expression of both. Okay, next case. That was a 61-year-old lady. This was sent as a clinically thought to be a lipoma of vulva. Again, skin excision. Epidermis is completely normal here, but here in the dermis, going down to subcutis, you can see something that on this magnification looks a little bit like enlarged peripheral nerves, but also something else in addition to it. So when you go on higher power, you can see tumor cells right here. What is, I think, most prominent on first sight is this very prominent granular eosinophilic cytoplasm, which is very helpful and kind of narrows down your differential diagnosis. Otherwise, most of the cells are epithelioid, some are somewhat more spindled, but generally the nuclei are again quite bland. There is no mitotic activity. And so with this morphology, with this benign-looking epithelioid spindle cell neoplasm with granular or spindle cell morphology with granular cytoplasm, you can think of maybe rhabdomyoma would be a differential here. So we can do desmin or MyoD1, both or desmin was negative, MyoD1 we didn't do, and the other very likely possibility here. Anybody has suggestion apart from my father? Who knows? Probably the diagnosis. It's a relatively common tumor. If you don't know, you can do just some basic immunohistochemical panel for mesenchymal tumors. So S100 cytokeratins, EMA, CD34, and so on, and you will get this result. This is again S100, diffuse strong positivity in virtually all the tumor cells. You can appreciate even better here the epithelioid morphology. In other areas more spindled. So that's S100. If you have S100 positivity, it's always important to add SOX10 because it will narrow down your differential based on the result. So this is also SOX10 positive. So you should immediately narrow down this to some neurogenic tumor, perhaps could be melanoma. I think some adnexal tumors can have this co-expression, and some myoepithelial non-adnexal tumors can have this co-expression. So I think that's pretty much the differential here with this morphology. I think already this immunoprofile is diagnostic for benign granular cell tumor. So it's a benign nerve sheath tumor, granular cell tumor. So granular cytoplasm, granular cell tumor. What can help you confirm the diagnosis is that these tumors are basically uniformly positive with calretinin and inhibin. So this is calretinin. Again, all the cells are nicely positive. Inhibin the same. It's enough to do just one, but I knew I will take this case for the seminar, so I stained both. So beautiful cytoplasmic positivity with these markers as well. So benign granular cell tumor of soft tissues. Okay, next case was a 82-year-old lady. She had a history of diffuse large B-cell lymphoma, and now was clinically said to have enlarged lymph nodes on her neck. We got two small samples. I'll show just this one because the morphology is the same in both. So rather than lymph node, this looks like just a fibroadipose tissue infiltrated by some eosinophilic cells, which predominate this, very lightly eosinophilic kind of like epithelioid cells. Then you can see dispersed lymphoid cells, mainly eosinophils, and lymphocytes. Already this combination is pretty helpful. So of course you can think, is this some recurrence of her lymphoma? You can do B-cell markers, although this doesn't really look like a B-cell lymphoma of any kind, as far as I can tell at least. Or you can think about its epithelioid, it could be some carcinoma. Perhaps it could be melanoma. The epithelial morphology would be good for it, but there are no mitosis, not much atypia. So if you are helpless, you can stain, cytokeratins, S100 protein, some other basic markers, and again you will get another S100 diffusely positive tumor, which is very helpful actually. Another thing that is helpful in this stain, if you look in the S100 staining, and you look very closely, hopefully you can see it in the camera as well. Some cells, the stain is cytoplasmic, so you get cytoplasmic positivity, and in some cells, if you look at this on the screen, hopefully we can find it, some of the cells are negative, such as this lymphocyte here, or the lymphocyte here, this one. And shortly in this stain, you can much better appreciate a very important diagnostic feature of this tumor, which is called emperipolysis, which basically means that the tumor cells, the large epithelioid cells, kind of like basically eat the non-neoplastic lymphocytes. It's sometimes quite difficult to see it in the H&E staining, so the S100 stain kind of helps. I don't want to spend too much time here with this. And I don't see a good example in the H&E. Some cases of this tumor, which is Rosai-Dorfman disease, have a striking morphological signs of emperipolysis here. The H&E doesn't show it that well, but the stain, S100 staining helps to find it. So this is a Rosai-Dorfman disease. Besides S100 protein, we get expression of histiocytic markers, because this is basically a histiocytic disorder. It was thought to be some potentially reactive proliferation, but now it's generally accepted this is just another neoplasm, very often with mutations in the MAP2K pathway. And actually this case had KRAS mutation confirmed by molecular. This is CD163, so it's one of the best histiocytic markers. You can see all the cells are nicely positive. So in the Rosai-Dorfman disease, you look for expression of S100 protein and CD163 or some other histiocytic marker, negativity with CD1A, which is a marker of Langerhans cell histiocytosis, negativity with Langerin, and of course negativity with everything else, which is important, like cytokeratins should be negative, CD30 should be negative, and other melanocytic markers should be negative as well. So Rosai-Dorfman disease can be a localized and then mostly benign disorder or neoplasm, or sometimes it can be, much less commonly, it can be like a generalized disease which can be life-threatening. Okay, next case. This was a 70-year-old male who had a tumor in his small intestinal wall. And this is what we received. Multiple blocks of small intestinal mucosa, which doesn't show any signs of dysplasia, but is diffusely infiltrated by this quite monomorphic small round cells with very high mitotic activity. Here in the center, hopefully you can appreciate the mitosis. This maximum zoom is not very good for the camera. Also, you can see prominent nucleoli in some cells, although it's not the most striking example. And of course, with this location, you can think of carcinoma, GIST, gastrointestinal stromal tumor. Those should definitely be on top of your list. Given the morphology, we can basically, I think, exclude any kind of hematolymphoid neoplasm. And of course, never forget melanoma. Melanoma can be anywhere, and as you know, can look like anything. So there was a lot of immunohistochemical stains done, and basically everything was negative. And so we just basically made a diagnosis of high-grade undifferentiated malignancy. Differential diagnosis in the first place includes undifferentiated carcinoma, undifferentiated melanoma, or undifferentiated sarcoma. It's basically all you can tell with morphology and immunohistochemical analysis at this point, and we sent it to molecular testing. And after 2 weeks, we got the results, and there was a BRAF mutation and third mutation, which in conjunction with this morphology and the negative immunophenotype is most likely to suggest that this is an undifferentiated melanoma. So that was the final diagnosis. Again, always think about melanoma wherever you are, whenever you look at a high-grade tumor which doesn't stain with anything. It's very, very common diagnosis. Okay, next case was a 71-year-old male who had he was clinically said to have a malignant-looking tumor in his right renal pelvis, which was biopsied. We got this very damaged fragments of basically unremarkable renal parenchyma. As far as I could tell, there wasn't anything. And also there was a second sample taken from his liver, and it was said to represent metastasis. And we got this beautiful sample where all you could tell is that these are hepatocytes with some inflammatory cells, and then all we could tell them is that this most likely represents malignant cells, which are, however, completely crushed and impossible to evaluate by morphology. Luckily, we don't have only morphology, so we did some immunohistochemical staining, and there was a pretty diffuse expression of cytokeratins. So these are the hepatocytes, obviously they are positive, but also the crushed, ugly-looking cells were here. They were positive as well. Just Chem 5.2, also cytokeratins AE1, AE3 were positive in a similar fashion. Again, here are some of the crushed malignant-looking cells. And then we did a broad panel of immunohistochemical stains, trying to kind of narrow down the differential to say where this could be coming from. So with arginase, hePAR, pulmonary markers, GIT markers, and so on, and everything. Eventually, we got most likely a reasonable result. This is GATA3, diffuse nuclear positivity. Of course, the GATA3 is not super specific, but if it's diffusely positive, it's most likely to represent either a tumor from the breast, but this is a male patient, so it's unlikely, or it can point towards, if we are speaking about carcinomas, it can point towards urothelial origin. And remember, the patient was said to have a malignant-looking lesion in his renal pelvis. So we also did P63 and P40, which are other two markers for urothelial carcinoma. And again, you can see beautiful, strong nuclear positivity. This is P63. Again here, and the P40s showed the same staining. So we basically said based on malignant-looking morphology, clinical impression, and immunophenotype most likely represents metastasis of urothelial carcinoma. Okay, so these were somewhat relatively common tumors, and now I'll show you some completely unique tumor, a new entity in not in WHO yet. It's so recent that it's not going to be included even in the upcoming WHO classification of soft tissue tumors, but it's definitely a new entity. There is absolutely no doubt about this. So this is actually, and hopefully will be, a 33-year-old male patient with a recurrent tumor on his thigh. And this is what we got. Sample from probably subcutaneous fat tissue. And there is this multilobular tumor, relatively well circumscribed, but not encapsulated. And what is crucial for this tumor, and what's very characteristic of it, is this osseous differentiation at the periphery, which is very, very helpful for the diagnosis. So right now, when we have a spindle cell tumor, which this mostly is, a spindle cell tumor with bone formation at the periphery, we can choose between myositis ossificans, which can have this morphology, or ossifying fibromyxoid tumor of soft tissues. And now this new entity, which I'm showing you, will be an addition to this list. As I mentioned, the tumor is predominantly composed of spindle cells, which are relatively bland. Sometimes there can be minor atypia. They have very often this fascicular or slightly storiform arrangement, as you can see here. And then in some other areas, such as here, the phenotype of the cells change to a more epithelioid-looking morphology. Actually, to me, it reminds me very much of myofibroma, which also has these spindle cell areas, myoid-looking, a little bit pinkish, which in some other areas change to this more epithelioid or round cell morphology with this gray, blue, hyalinized stroma, as you can see here. Still, if you look on higher power, here are some minor, mild to maybe moderate atypia at most, but really no mitotic activity here. So we have a osseous differentiation at the peripheries, predominantly spindle cell morphology, and epithelioid morphology in some other areas. Now, of course, you should do some immunohistochemical stains. You can again do the basic panel, EMA, cytokeratins, S100, desmin, and you will get these very helpful immunohistochemical results. This is a cytokeratin cocktail, so broad spectrum cytokeratins, and you get pretty diffuse positivity, especially in the epithelioid cells, but not only. Sometimes it's quite focal. In this case, it was pretty remarkable positivity. Pretty much the same pattern you get with EMA. And you also get pretty often focal or patchy expression of S100 protein, such as seen here.
Second case we have?
This is the first case we have. And if you, so this is a newly described entity, which is called ossifying spindled and epithelioid tumor, described by John Gross. This is paper from Modern Pathology, probably from like a month ago, so very, very recent. In this, to identify or diagnose this tumor correctly, it's very useful to have the radiological features, because you will almost universally have radiological finding of osseous capsule, at least partial osseous capsule at the periphery, such as seen here, or even in the gross evaluation you can find it. And then the morphology is kind of variable. This is what I've shown you. The case we had is the most typical one, but pretty often you can have there also some giant cell differentiate or giant cell component there, which can make you think or change the differential. But you can see the epithelioid cells are pretty often quite remarkable. Also here, sometimes it's admixed with the spindle cell component. In other cases, it's more detached from the spindle cell areas. And this is the cytokeratin expression, most commonly limited or predominantly in the epithelioid cells. And this combination of findings kind of gives you this diagnosis. Actually, it's a very interesting story of this tumor. This was identified by John Gross basically by looking at the radiologic findings and at the morphology. And the molecular features of this tumor was found out only later, because there are like 2/3 of the cases had NFET-C3 gene fusions. The problem with NFET-C3 gene is that it until now, it hasn't been associated with any neoplastic processes, so it's missing in almost all gene panels currently used around the world. So although these tumors were sequenced at like 5 different institutions, including our lab, nobody has found the fusion because the gene was not examined by the gene panels. So eventually, John asked somebody in John Hopkins core lab, genetic lab, to do whole transcriptome sequencing, and they found the fusion. So in contrast to most new entities today, which are identified based on sequencing, and you get the same fusions, then you collect the cases together and look at them. This tumor has been identified in the old way, based on morphology, clinical features, and radiological features. I forgot to mention the most common clinical scenario. These tumors are typically found on the extremities, typically the lower extremities or other superficial soft tissues. But the extremities are like 3/4 of cases are on the upper or most commonly lower extremity. And so far, all cases have behaved in a benign fashion. Actually, our case is the first one I know about which has recurred. So a new entity. Unfortunately, the WHO now needs 2 case series of at least 5 cases published by 2 different group of authors to include an entity to the WHO classification. So this tumor will not make it there until there is another paper about it by some different people.
To this topic, I might add that we plan to start whole transcriptome sequencing at the end of the year or at the beginning of next year. The only problem about it is that you need a new sequencer, which is called
Seq X.
Seq X Plus, and it costs 40 million crowns, so that we must spare 40 million crowns somewhere. And next leap forward will be in introducing this amazing method in the future. I hope at the latest beginning of next year we will start all transcriptome sequencing in all interesting tumors. Yeah.
Okay, next case was a 38-year-old gentleman with a 1.5 centimeter tumor on his in his soft tissue around scapula. So again, fibroadipose tissue, so somewhere in the cutis probably. And here you have this uncircumscribed, kind of like infiltratively growing small tumor. On higher power, you can see pretty cellular proliferation of spindle cells again. What is quite remarkable is the diffusely present, mostly lymphoplasmacytic infiltration in the background. And I won't use the highest power because it's not very nice. But perhaps here also you can see the cellular details, spindle cells with long eosinophilic projections, which are kind of very good or morphologically suggestive of myofibroblastic differentiation. So it's not a smooth muscle where the nucleus is longer, more cigar-shaped. This is more myofibroblastic appearance. And again, now it's time for, okay, there are not many mitoses, no atypia, so some bland spindle cell proliferation with inflammatory background. So we can do some immunohistochemistry. This is smooth muscle actin, pretty diffusely positive, with the myofibroblastic pattern, which is nice to see here. It's called tram track pattern, where positivity is found at both, especially at both sides of the cell, basically at the cell membrane, such as here. If you look at the screen, this cell, for example, that's a perfect example of a myofibroblast. And okay, so we can think about what has myofibroblastic differentiation in soft tissues. The first and most common lesion with this morphology is just a common scar. So that could be some scar tissue, but it's unlikely. There is no history of any surgery here. It's pretty large, pretty infiltrative. It could be some tumor, of course. And one of the relatively more common myofibroblastic tumors is inflammatory myofibroblastic tumor, which typically has ALK rearrangements. And indeed, this is ALK immunohistochemistry, diffuse positivity found. And there was also ALK fusion. So this is a good example of inflammatory myofibroblastic tumor. So looking back at the morphology to kind of help you to burn it inside your eyes and memory. Notice the spindle cells, they are spindled, but they're relatively plump. They are not too thin, they are relatively plump. It's quite important because I'll show you some other myofibroblastic tumors shortly. So that's soft tissue example of IMT. And now this is a different case. This is an elderly lady with a cyst, 4 centimeter large cyst in her abdominal cavity. And indeed, we have on scanning magnification, we have a cystic lesion. Inside of the cyst, there's basically just blood and fibrin. And in the cyst wall, you can see something that's pretty similar to what we just saw in the previous case. So we see myofibroblasts, lymphoplasmacytic infiltration, lymphoplasmacytic background, but this is actually not inflammatory myofibroblastic tumor. Something I would say much more common, or at least I get to see it much more commonly in consultations, because it's very often thought to be IMT, but it doesn't stain like it doesn't have ALK rearrangements. So myofibroblastic morphology, but the cells are a little bit more spindled, more thin, more slender than in the IMT case. ALK immunohistochemistry would be negative. And what will help us make a diagnosis are other immunohistochemical stains. So we can do, again, smooth muscle actin, but these are indeed myofibroblasts, so that they will be, again, nicely positive with SMA. Again, the tram track pattern, seen here. Then you should do the basic immunohistochemical panel. This is cytokeratins AE1, AE3, show diffuse positivity, which is the moment when many people start to get scared and think about some carcinoma or something really bad. If you do EMA, you will get the same staining pattern. You can do Desmin. Desmin will be very often positive as well. Very important stains to do here are mesothelial markers. This is WT1, one of the good mesothelial markers, which should show nuclear positivity in order to be called positive. But here indeed you see pretty diffuse nuclear positivity in the lesional cells. You can do other markers of mesothelium. This is calretinin. Again, diffusely positive. So this you can of course start to think about mesothelioma. And that's when the morphology is very important, obviously. It's always crucial to evaluate any histochemical stains or immunohistochemical stains in context of the clinical findings and morphological findings. So clinically, the patient didn't have any recurrent effusions, which is very often associated with mesotheliomas. There was no clinical suspicion of mesothelioma, and morphologically you basically get to see pretty bland, although cellular in some areas, but pretty bland spindle cell proliferation. And then you get smooth muscle markers positive, epithelial markers positive, and mesothelial markers positive. So this combination of features, clinically usually unremarkable, or there can be a clinical history of some operation very often, or some inflammatory disease in the abdominal cavity. And this is actually, there are variable terminologies for this, but these are reactive changes. It's usually described as proliferation of submesothelial fibroblasts. And basically anytime anybody or anything makes the serous lining injured, angry, basically, they get angry and they start to proliferate and create these pseudosarcomatous lesions that resemble inflammatory myofibroblastic tumor or mesothelioma and look pretty scary. And very often this is sent for consultations, and I would expect that unfortunately it's also very commonly signed out as possible mesothelioma, or in better case as inflammatory myofibroblastic tumor. So proliferation of submesothelial fibroblasts. The immunophenotype is crucial. Cytokeratins, mesothelial markers, smooth muscle markers. This combination.
Precise location.
This was an abdominal wall, a cystic, a 4 centimeter cyst. Another case, 46-year-old lady, tumor on her shoulder. I'll show 2 last cases and then I'll go away. So this is probably the best slide. So again, soft tissue lesion, uncircumscribed, infiltrative. We go on higher power. Again, we see spindle cells, very plump in some areas. These have also quite prominent nucleoli. And then sometimes you get cells that look a little bit like ganglion cells, as you can see on the screen here. In the center, the larger cell, this looks like a ganglion. So this is pretty common in inflammatory myofibroblastic tumors. This is another example of inflammatory myofibroblastic tumor. Again, lymphoplasmacytic background. Again, smooth muscle actin was diffusely positive, and ALK was diffusely positive. And again, ALK fusion was found. So this is another summer case of inflammatory myofibroblastic tumor. And another case, my last case, this was an adult patient with a lesion under his liver, which was clinically thought to represent acute cholecystitis or some other inflammatory lesion. And we get this little sample. It was, I'm basically citing the documents. It was thought to be inflammatory myofibroblastic tumor, but ALK was negative. So what is this? And now you probably know what it is. Again, myofibroblastic cells, basically perfect example here. Very bland, very slender. It's inside of the abdominal cavity. So what would you stain? I'm asking the young folks here. What would be the stains you would do? Peter, Inka, Pepo?
Cytokeratins, epithelial markers.
So these are cytokeratins. All the cells basically here positive. Mesothelial markers, you said, right? So this is calretin, diffuse. WT1 was nuclear positive, and what other markers?
Desmin.
Yeah, desmin also, and this is smooth muscle actin. Maybe I even have desmin. Yeah. So this is desmin. It's usually not 100% of cells, but some cells are positive here. So, and all goes negative. And in conjunction with the bland spindle cell morphology, you can be pretty sure this is a proliferation of submesothelial fibroblasts again. So that's all from my side. Thank you for attention.
So good afternoon to everyone. Here is Sveta Mikova. My first case is just a routine case from orchidectomy, and this is a 25-year-old patient. And his, or it's not a proper designation, his, because this is a morphology of orchidectomy, of transsexual, of transition of male to female, and this patient undergoes hormonal therapy, or had been undergoing hormonal therapy, and now there is a surgical treatment of or surgical transformation of male to female, and this is a typical appearance of the testicular parenchyma in these patients. So what we can see here are germinal tubules which have there is no spermatogenesis. There are hypoplasia of germ cells, and the predominant cellular population inside the germ cell tubules are sertoli cells. The only remaining germ cells are the largest cells within the germinal tubule, and also there is quite prominent peritubular sclerosis. Also, there are no Leydig cells because of the preceding hormonal therapy. So this is just an interesting morphology, given the fact that you, if it is a case from faculty hospital, which this was, and you have available the clinical information, the diagnosis is very straightforward. But recently there has been an increasement in biopsies like this. So this is a typical morphology of transsexualism in transformation from male to female. My second case, it is a case which is included in a study. Otherwise, it is very rare, and it is from testis as well. You can see testicular parenchyma somewhere here. There is a non-tumorous testicular parenchyma. In comparison to previous biopsy, you can appreciate here the normal spermatogenesis. The smallest rice-like cells are spermatids, which are in the center of the germ cell tubule, and there is a predominance in comparison to previous case of germ cells within the germ cell tubule. So the spermatogenesis in this, at least in this germ cell tubule, is normal, and here you can appreciate the Leydig cells in the interstitium of the testicular parenchyma. But back to the pathology here, what you can see and what you can quite easily identify is this chondroid tissue, which belongs to teratoma. But there is not only teratoma, but also the predominant tumorous tissue is composed from this tumor. And this is so-called somatic malignancy arising from germ cell tumor. Somatic malignancy, the definition is the transformation of some elements within germ cell tumors, and they can transform into sarcomas, carcinomas, or nephroblastomas, like in this case, and various malignancies which resemble the true somatic malignancy outside the urogenital area, or the testes, or outside the testes. Here you have otherwise typical appearance of nephroblastoma, which is a rare tumor of the kidney in children. So we have three components of this tumor in typical cases, composed of epithelial structures, here in the form of tubular or smaller glands. Then we have blastemal component, which are these undifferentiated blue cells arranged typically in solid formations, and then in this more spindled areas there is a stromal component of the Wilms tumor. So somatic malignancies typically arise in patients which underwent chemotherapy before, and these tumors are much more aggressive than malignant germ cell tumors, but there has to be at first malignant germ cell tumor to give rise to much more malignant and usually chemotherapy resistant somatic malignancy within germ cell tumors. These are much more common in metastasis, but also can appear in primary testicular tumors, or primarily in the testis, like in this case. So this is the second case. And third one, this is a tumor of the mediastinum, and the patient was born in 2025, so it's newborn. And what you can see here, it is a little bit, if we find chondroid tissue, it would be similar to the previous teratomatous component, because this is teratoma of mediastinum. So it means it is a primary germ cell tumor arising in mediastinum. This was tumor of anterior mediastinum. And there is the anterior mediastinum is after ovaries and testes, the second most common location of germ cell tumors, if we exclude secondary tumors. And in this case, because we have newborn and female patient, it is an anterior mediastinum. There is almost no chance to be metastasis from the gonads. It is a primary mediastinal tumor, and in this case, it is a pure teratoma. And here in the circles, you can see this dark purple structures, some of which are arranged in the pseudo-rosettes. So this is a non-mature or neuroepithelium. This means that these are structures of unmature teratoma, but given the fact that these are not in larger space than these are occupying less space than one a low power field, this is grade 1 unmature teratoma, and the biological behavior is benign, is probably congenital with this patient. So unmature teratoma grade 1 in infant of probably congenital origin. So otherwise in other fields there are normal structures of teratoma, including mainly glandular structures, and this here is chondroid tissue and unmature neuroepithelium.
It is the classification of Frank Norris. Yeah.
Frank Norris.
I heard that Frank Norris is now nearly 90 years old, and he is homeless now. Really?
I didn't know that. And my last case it is from uterus. It is endometrial polyp, and here we have appearance in this area of like classical endometrial corporal polyp. But in these areas, there are some structures which are a little bit worrisome. I mean, these papillary proliferations within the hyperplastic-like glands, and there is also some metaplasia within these glands. There is a so-called syncytial or eosinophilic metaplasia, and also mucinous metaplasia here in this gland, for example. This condition, because we have these weird looking glands in less than 50% of the polyp field, and there is only simple papillary proliferation within the glands. I'll use my magnification. It means that there are no hierarchical branching within the glands. There are no fibrovascular cores within the glands, and this is a benign finding. And these, if the morphology of the polyp fulfills this criteria, meaning that these weird glands are in less than 50% of the polyp, there is lack of fibrovascular cores and hierarchical branching. There is almost zero chance to transformation these changes into the malignancy, and it is recommended to call this condition as focal simple papillary proliferation, and it is a metaplastic rather reactive change if it fulfills this criteria. Also, the papillary proliferation which exceeds the 50% of the polyp, usually there is a polyp which is composed entirely of much more wild-looking endometrial glands. Then there is a recommendation to classify these as endometrial interepithelial neoplasia, and these have more than 50% chance of transformation into the endometrioid carcinoma, but not in this case. So the diagnosis in this case is focal simple papillary proliferation within the corporal endometrial polyp. And that's it from my side. So thank you for attention. I don't know.
Okay, we did one case. Right. Michael Senior. Yeah, I got this skin or subcutaneous lesion, which was sent to our laboratory with the diagnosis of lymph node metastasis of neuroendocrine tumor or small cell carcinoma, but lungs were negative. And when I looked all over the slides, I didn't see anywhere sinuses. So I don't think it's lymph node. And it's very important because if it is not lymph node, it must be primary tumor. What was further dissuading? Because then the diagnosis is microcell carcinoma of the skin. And when we did polyomavirus staining, only lymphatic tissue was positive and the tumor was negative. So that it's important not to diagnose it as or take it against the diagnosis of Merkel cell carcinoma, because there are two types of Merkel cell carcinomas. One of them is caused by the virus, second one is without virus, and those that are not caused by the virus are usually retinoblastoma protein deficient. Proficient, yeah. Deficient, sorry, yeah, deficient. And when you see this deficiency, you have the Merkel cell carcinoma again in the play. And then what is helpful is to make immunostaining for ENSM1, which should be always positive, and the same staining for SEB2, which was positive as well. Yeah. So, what was the message of that? It is very important, because if you would call it just metastatic of neuroendocrine carcinoma of unknown origin, the patient would not get biological treatment. There is specific biological treatment for Merkel cell carcinomas, and one of the centers is in our city, in Faculty Hospital. Yeah. And if you see Merkel cell carcinoma negativity, immunostaining for Merkel cell virus, you should always think about the second type. And the best way to prove it is to make whole sampling and look for epidermis, which has in situ component, which is squamous cell carcinoma in situ, and this in situ component is retinoblastoma deficient, which is this final proof and very specific one. Yeah. Okay, is this okay? What was the time? It's 28, so that I would probably close out today's session. Thank you for attending.
Next week.
No, next week will be. Next week we will start the regular seminars like the last year. Yeah, that means Tuesday, 14 hours 30 minutes. Okay, thanks.